Thanks, everyone. I'm just going to give you a little talk today on my NIHR-funded development of a clinical post-mortem micro-CT service. So to give you a little bit of background, miscarriage is obviously an extremely common event both in the UK and around the world, and obviously very traumatic for the families involved. And what parents want to find out after a miscarriage is why it happened. And we know that autopsy provides the greatest diagnostic yield and often finds new clinical findings in up to 70% of cases. But around the world, lots of studies have shown that declining rates mean that many parents don't have the opportunity to find out why this pregnancy loss occurred. Now, here at Great Ormond Street Hospital and in other centres around the world, we've been developing less invasive options, and some of these even are non-invasive imaging techniques. So what can we use? Well, we've got here at Great Ormond Street and other places X-rays, CTs, MRIs, and ultrasound. And all of these are fantastic at delivering diagnostic accurate information without any invasive procedure, but only for over 20 weeks gestation. Below 20 weeks, the babies are too small, and the resolution of these imaging modalities is just too poor. So we can't get the accurate diagnostic information we want. Now, back in 2014, Dr. Lombardi et al. And his team in Milan did a study where they used micro-CT. So micro-CT is a technique that's been around for a long time and historically been used in the industry and archaeology. It is really good at getting high resolution detail, so we can get down to micron level resolution. So each dot on the screen is 1,000th of a millimetre when we're using it for small specimens. And he did a study showing that of 21 cases, when they did a conventional autopsy and a micro-CT autopsy, that actually the results were comparable. And in actual fact, the micro-CT showed a greater degree of information than the conventional autopsy. But what hadn't been happened in this study from 2014 was that technique had not been optimized for clinical usage. So what I wanted to do with my NIHR funding was to optimize the technique that was required, to then prove clinical viability, prove that a clinical test could be made that is useful in the environment, to prove whether parents want to choose it, and then to come out with a clinical impact within 5 years. So first of all, what I needed to do was to identify an appropriate tissue preparation. If we don't put contrast agent into these babies, we get images like this, where you can see the calcified skeleton, but you can't see anything else of detail. It's just other tissue, and you're not sure what to do. Once we put some contrast in, you can see the difference. We can see all the, in high resolution, all of the internal organs, and we can make some assessment as to whether there's any abnormalities there that may have caused the pregnancy loss. So we identified iodine as the contrast agent. It's safe and cheap and can penetrate for several centimetres, but nobody had done any investigations as to what concentration to use and how long to place these babies into this solution. So my study took all the patients that were referred for a year, 150, and we saw the affiliation with body weight and immersion time, so that now we've got an equation that basically, when the mortuary tell me how much the body weighs, I can tell them exactly that it'll take 10 days to iodinate or 2 days to iodinate. And we can give that information both to the clinicians and to the mortuary, but also to the parents, saying how long these scans are going to take before we can do them. Following this, what I wanted to do was to optimize the image quality. I'm sure when you've seen radiographers go up to the ward, you've seen people fiddling around with X-ray factors. It was the same with this. We need to optimize it and find out what factors were going to be best in this circumstance. But it was no good me coming up with brilliant images that take 24 hours to scan, because that's not a clinical technique. We want something that's easy to implement within a clinical service. So I set myself the challenge of being able to gain a data set, an imaging set, within 30 minutes. And you can see here from changing the kilovoltage what a difference it can make. So when we take this into consideration of all the different factors, we really need to do some quantitative assessments. And I did that to come out with a clinical protocol for it. Thirdly, what I wanted to do was I wanted to assess from all these patients that we'd scanned, what were the image quality predictors? Could I predict before we scanned the baby whether we were going to get high image quality or low image quality? And therefore, tell the parents and the clinicians which babies this technique was going to be the best for. And what came out as the key predictor of poor image quality was maceration. And maceration is the breakdown of tissue post-death from the enzymatic action of the enzymes within the body breaking down the tissue, but also from our body being within a fluid-filled stack, i.e. before delivery. And effectively, the maceration therefore breaks down the tissues internally and externally. You can see here on the right-hand side of the screen that when there's no maceration of this brain, you can see beautiful detail and we can see whether it's developed normally. But once we get severe maceration, as you can see, it's very little diagnostic information available. What I did then was I added all this information together to create a clinical protocol, whereby it was a step-by-step guide that was published in a real high-impact journal, Nature Protocols, that literally took a clinical team to how to develop this situation, develop this system, this clinical protocol. And we therefore scan 3 areas of the baby within 90 minutes. So we do a whole scan for 30 minutes. We then do 30 minutes of a higher detailed head, and then 30 minutes of a higher detailed thorax and abdomen. And you can see the images that we come out with here are really detailed when this is a 15-week fetus. So there's approximately 10 centimeters in length. It's really, really small. What I then wanted to do was to assess whether the parents who had experienced miscarriage, whether they would have consented to this technique, whether they would have chosen it. We took to them and it was a wholly positive response. All of the parents who came to our focus group said they would have chosen it if they'd been offered it. And when we asked them what were the benefits of this technique, they said the fact that it was such high resolution, that it was non-invasive, that it gave them hope for the future because they can find out the reason why it might have happened. And through all this, it was continued care and protection of the baby as it was non-invasive, but also giving them an increased investigational choice, something that they wouldn't have had if this technique wasn't there. So all the way through my doctoral journey, I kept trying to remind myself that I have to have clinical impact for this to be a real impactful service. And I took all of this into consideration. So where were we 4 years ago? Well, these are the images that we would have got from CT, conventional CT and MRI scans of a 15-week fetus. And as you can see here, they're really poor diagnostic quality. It's purely down to the resolution of the scan and the very small size of the babies. So these parents would not have been offered an imaging test. They could only have had either an invasive autopsy or an external examination. There were no imaging tools available. But now what we have here at Great Ormond Street Hospital is a world-leading clinical service. It gives increased parental choice. It's non-invasive, it's high resolution, and it can possibly provide answers that can inform on future pregnancies and give the parents some form of closure, having found out the reasons, or maybe they didn't find out the reasons, but they still have investigated to the best of their ability. So now I'm in the process and I've been busy trying to prove what a clinically impactful service this is. And this is the number of micro-CT scans that we've done here at Great Ormond Street Hospital myself over the past 4 years. And you can see now we're over 750 patients. Started out small numbers, but we're now on track this year to do over 250 a year. And it just keeps on growing, keeps on making me busier and busier. So what I thought was also interesting is there's approximately 550 patients referred to Great Ormond Street Hospital for autopsy, not forensics or coroners, but for general autopsy in Great Ormond Street Hospital last year. And 220 of these were eligible for micro-CT. That means that they were less than 300 grams. If they're over 300 grams, we can use conventional imaging of MRI, ultrasound, CT, and the like. But of those 220 patients, nearly 90% of parents consented to micro-CT, and we were able to carry out micro-CT. And of those 12% that didn't, either they often didn't want any investigations at all, they just wanted an external look at the baby, or they may actually have chosen to have a full investigation, a full conventional autopsy, because that's what they felt was the gold standard and that's what they wanted. But I think these numbers really speak for themselves and show that actually parents want this and we're able to provide it at the moment. So I'd just like to say thank you to my supervisors, Owen Arthurs and Neil Severe, and to the Miscarriage Association, who've been really helpful in developing animations with me, in developing plain English statements, helping recruit studies, and ongoing to plan my next study. And of course, everyone at Orchid and ICH, but of course NIHR for paying the bills and providing the funding as well. So thank you very much.